Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hi, I'm Dr. Eileen Ruhoy, and welcome to episode number 13. Ooh, it's an unlucky number. Or is it lucky number? No.
We'll call it lucky.
This is our conversation for Unraveled Understanding Complex Illness with my co-host, Dr. David Kaufman. And we are going to tackle connective tissue disorders, or connective tissue in general.
Right. Another topic we'll knock it off in 15 minutes. We won't need any more episodes.
There's not much to say. Or as you said, everything that we're made of.
That's right.
I think, I don't know as an internist how much you did about connective tissue zero. I could tell you that as a neurologist, I did close to that as well in terms of training, in terms of just even learning about it and treatment.
I would say that in my 30 plus years in New York, before I moved to California, the two words connective tissue probably never entered my mind.
It's so true.
In patient care.
And what's interesting is that, there isn't a whole lot of research on it, or a whole lot of, I should say, writing, like textbook style kind of stuff. I found a couple of books. I found a couple of articles. They're usually in the rheumatology world, but they seem to be within the context of autoimmune disease, and we know that things like Sjogren's and lupus, rheumatoid arthritis are actually thought to be, in some circles, connective tissue disorders, but are not treated as such.
I was just going to say, yeah. I don't want to mislead people. It's not that I didn't look at muscle spasms and tendinitis and bursitis and
right. We were doing connective tissue before we knew we were doing connective tissue.
I never put it in the context of connective tissue.
Exactly.
Right.
And I think what has been a rude awakening for us is that, wow, connective tissue really does matter. And then when I think about, I don't even practice neurology anymore. In fact, Dr. Bolognese often says, I'm just sort of out there, like I'm a bird. I'm practicing some weird pocket of medicine, right. Because, I think more about connective tissue than I think about anything else these days. And it's because it's so fascinating to me. And when you think about the body mechanics, and when you start to read into the development of connective tissue and the different types of connective tissue there are, and the different types of cellular components of connective tissue, and you realize that the spatial mutual relationship of every piece of us is actually genetically determined. Did you know that?
Yeah.
I mean, that was mind-blowing to me when I learned that a couple of years ago. So, and I often tell patients that when something is not in where they're supposed to be, right, then things don't function optimally. And so it doesn't mean you necessarily have a severe pathogenic state, though you could. It just means that the signaling between one tissue to another tissue, one cell to another cell, one organ to another organ is just off, just slightly. Even if something is moved in a millimeter, then the signaling, which is, a lot of what happens in our bodies is all about cellular signaling. In fact, when we develop as an embryo, cells know to migrate to a certain spot anatomically, right, and to differentiate in a certain way because of a signal that they read. And in fact, in neurology, there are some, what we refer to as migration disorders, where the cell is meant to migrate somewhere, loses a signal, and stops. And so a cell is where it isn't supposed to be, right, kind of thing. And that causes certain disease states. But regardless, if something isn't where it's supposed to be, then they don't talk to one another well enough. And so things don't function as they should. And I always give sort of a ridiculous analogy. I always say that, if you're calling out to your friend who you think is on the corner and you're yelling her name, but she's not turning around, it's because she's not really on the corner. She's around the block, or around the corner. So when I think about that and how important our body mechanics are and how important our alignment is, and then I think about how the connective tissue, its role is to sort of keep things in that alignment, and it's failing, then I really understand where things go wrong.
Right. But I'll turn this into a question. Okay.
Sure.
So if we look at connective tissue the way you just described, which is related to genetics and embryologic development, et cetera, And we know that there's lots of room and lots of times for mistakes.
Mm-hmm.
The remarkable thing, the beautiful thing, is that we adapt. So we're probably all walk around with some errors and some mistakes and some, this isn't connected the way it should connect, but we are fine. We adapt to that until something makes us not able to adapt.
Exactly. That's exactly it. We all compensate, right? We all do. I mean, I've known lots of people with scoliosis, for example,
right.
Or a bad knee, or some slight, disruption of some homeostatic mechanism for whatever reason that causes some symptoms, but they compensate and they're functional and they deal with it. They might take some over-the-counter med. They might take some prescribed med. They might just change their diet. So there's a lot of ways that they just live with it. Exactly.
Or even more, they make it into an asset. So let's just call it out. There's millions upon millions of people with hypermobility, Ehlers-Danlos syndrome, and they're totally fine and doing great in Cirque du Soleil and on the ice skating rink and in the gymnastics and at the Olympics.
Oh, absolutely.
They're not sick.
No, they're not sick at all. In fact, they're thriving because of their hypermobility, because they are at a functioning at a level that we can only imagine in our dreams, right? So I agree, and I've said that before, even on this podcast, I believe, but I don't believe being born hypermobile is a pathogenic state.
Right.
I think it provides you with certain abilities to do things that are pretty amazing that a human can do. But you're right. It's sort of when it's like that 2-hit kind of thing, right? So you're born with this 1 hit, and then most people just do just fine. But then the second hit comes along, and that can be in the form of infection, in the form of exposure to some environmental toxicant or contaminant, physical trauma, emotional trauma. We know that, for example, childhood adverse events can create a lot of stressful milieu of the body, so which is in some respects just another inflammatory response, or at least an insult to the neuroendocrine axis. There's lots of things that can result in sort of the second hit that results in further degradation of the connective tissue, where it was just holding on, now it can't hold on at all, and it sort of falls apart.
I mean, for me, one of the aha moments of my years of working with you and talking to you and working with Bolognese and some of the other people, if you would ask me 15 years ago about connective tissue, I'd sort of say, well, we're born with this skeleton and these muscles and fascia and muscles and tendons, and that's what we got. And it doesn't really change, except you get stronger or weaker depending on what you do, and if you get hurt, that's a different story. But the connective tissue is there. It's just like a constant, okay? And what I came to realize, this is the aha part, in the last decade, is that's absolutely untrue, that it is subject to cumulative incremental insults, which at some point you begin to pay a price for. And the source of those insults, when all is said and done, is inflammation and chronic inflammation from whatever cause, not just infection, mast cell POTS, coronary artery disease, atherosclerosis, renal insufficiency, some of the usual old-fashioned nuts and bolts stuff from medicine.
Right.
And I'll take it a step further, but this is not a good topic for this episode. I'm sort of evolving this idea that that's actually what aging is all about.
Yeah. Oh,
aging
for sure.
is, we know it's chronic inflammation, but it's the effect on the connective tissue structure of our bodies that leads to the diseases of aging and unhealth, lack of health, dishealth, and ultimately dying.
I 100% believe that. I really do, just from my work in the connective tissue world.
Right.
I mean, connective tissue is everywhere, as you said. It's people always think of it as the joints, right? Because we talk about hypermobility, so obviously it implies the joint involvement. So clearly that's involved. But it's, it lines our vessels, it lines our organs, it lines our respiratory tract, our GI tract. It's within the organs. All of our visceral organs. It holds each of those organs where they're supposed to be. It sort of buffers them. The meninges are connective tissue. So there's connective tissue of our eyes. There's connective tissue of our ear canals. Connective tissue is literally everywhere. And it's different types. And it's made up of different cellular components sometimes. And that's the other intriguing part about connective tissue. It is not just one kind of tissue, right? So there's the cellular component, and then there's some people refer to it as the extracellular matrix, and some say it's the intercellular matrix. Regardless, it's the buffering around the cellular components, which and it actually makes up more than the cellular components. And it has a whole, it supports nutrient transport. It supports metabolism. It's got trophic functions. So with regards to the signaling that I referred to earlier,
Right.
it is remarkable what the connective tissue does. It's an entire system in and of itself. It's an entire highway in and of itself. And it's so important for our homeostatic mechanisms. And it is absolutely involved in the aging process,
Right.
and is probably the cause of, I would say, at least 50%, if not a whole lot more, of what we see with aging. And I think that it's not given enough credit. And I think it's not talked about enough. It's certainly not researched enough. We're doing a lot of research right now over at Mount Sinai on it. But we know that viruses, specific, and including COVID, by the way. In fact, there's a couple of really interesting papers that show that COVID degrades connective tissue, and it results in CCI, for example. As we've seen a lot of CCI in our long COVID patients,
Yeah.
and I think that they were previously healthy, and now for them to hear me say you need craniocervical fusion, I think they're all like, "What?"
Well, I think it speaks to what we both were just saying, that you don't have to have a connective tissue disorder, example, hypermobility, EDS. I don't even know if I should call it a disorder, but a condition, to develop connective tissue problems. Right?
Right.
And it's clear. I mean, I wouldn't have believed this, frankly, a couple of years ago, but it is absolutely clear to me that whatever the source, chronic inflammation damages connective tissue and can damage it to the point that you develop full-fledged cranial cervical instability without a shred of EDS genetics. Okay?
I
It
100%
just happens
agree with
sooner
that.
if
I'm
you have
so glad that
EDS.
you said that, because unpopular opinion of mine is that I'm not so sure we should be calling this EDS, frankly.
Right.
I think this is an acquired connective tissue problem. EDS, as you know, these are genetic syndromes. We basically know the molecular defect for, I think there's 13 different subtypes. It encompasses like 19 different genes. This hypermobility type EDS, which we call it, and I think for ease sake, it's fine to say it, but we don't know the molecular defect. We haven't yet honed in on a gene, though I hear that some labs or one lab in particular is getting close. Right. So I'm really curious about that. But from my patients and from the history, the bulk of them were flexible early on in life, definitely. But until they had A and or B and or C happen, right, they didn't have any of these symptoms. And so I wonder if there's just this acquired nature of this connective tissue dysfunction that's not genetic at all. And hence then maybe it's not like an EDS kind of picture, but it doesn't mean it's any less or more a disorder in and of itself, right? I'm just talking about labeling now, I guess, and I guess tomato, who cares? But
I tend to think of it a little differently, which is that if a person has, quote, hypermobility EDS, their glass is already half full. They're a couple of steps closer to the cliff edge, should they then develop all the chronic inflammatory illnesses we're talking about. But that doesn't mean that somebody who's got solid connective tissue isn't going to be in trouble if they are subject to the same risks in chronic inflammatory illness. So you might get injured sooner with EDS.
Right. It's just like a risk. It's a risk factor.
It's a risk factor, just like having parents with heart disease is a risk factor.
Right. Absolutely. No, I agree. And EDS is a well-known connective tissue, set of disorders for sure. Right. And I do think that labeling things, EDS is important because it gives you ideas in terms of surveillance. I mean, obviously you always want to make sure that their vessels are healthy because that is a big risk factor. So, I do a lot of echocardiograms. I'll do cerebral kind of angiograms and venograms, but, and, also keep on top of their joints and make sure they have healthy joints. And there's a lot of things that we do for healthy joints. As you know, we do a lot of peptides and a lot of physical therapy. And I always stress the importance of an EDS literate physical therapist because they really understand that kind of body so they don't move it in an untoward way where there can ultimately be actually some injury sustained. And so I think it's really important. But I think that a lot of the reasons why the hypermobility is part of the septat is because, as we know, the connective tissue, mast cells are everywhere, but connective tissue has its own set of mast cells. And like I will explain to patients that, if you have normal connective tissue, meaning the architectural integrity is nice and tight and strong and resilient, those mast cells are very much protected from things that are just floating around in the blood. But if it becomes a little bit loosey-goosey and you get some laxity, then they're not nearly as protected, and they sort of see things that they otherwise probably would not see because we're exposed every day.
Yeah, and even the laxity itself, the tissues get overstretched, and that is a stimulus for degranulation. degranulation.
And that's a stimulation, exactly, right. So,
which
right.
then degrades even
So
further.
it's even two-pronged, right. So the stretchiness of the connective tissue, specifically of the collagen fibers, does promote mast cell degranulation, but so does sort of, again, this additional exposure to things. And again, we are always exposed. I mean, I ate a bagel this morning, which I'm sure was not organic, and probably the simple sugar made my mast cells very angry. My point is that there's every day there's something that could make a mast cell feel like that they need to come and be a first responder and combat whatever they perceive to be the insult or the injury.
Well, and again, somewhat similar to what I said earlier about that we adapt to problems.
Right.
We are exposed to this garbage all the time.
All the time.
All these toxins, all these environmental insults, mold, mycotoxin,
Everywhere.
Poison food, etc. And most of us don't seemingly get sick.
Right.
We have, as part of those millions of years of evolution, developed pathways to detoxify all this crap that we take in. But at some point, for some people, there's just too much, and then the glass overflows, they tip over, and then the shit hits the fan.
Right, exactly. And it seems like once that happens, then it really is this progressive nature, and it's sort of a downward spiral.
And patients will tell you. It's amazing. If you listen,
absolutely.
If you ask a few questions and listen, they will tell you, I was fine, then this happened, and this happened, and this happened, and then all of a sudden this happened.
Mm-hmm.
How could that be?
That is totally the story.
It's hear it over and over and over.
Yeah, and that's why I think that, again, history is super important. But when I think about the components that are involved, in fact, the cellular components of the connective tissue itself include mast cells and macrophages and granulocytes. It also includes, though, stem cells in every different state of differentiation, right? So there's stem cells that it's trying to regenerate because it's that important of an organ system in our body, the connective tissue, right? So, I mean, even if you think about, I even go back to thinking of the basic stuff you learn in medical school, hernias, right? It's a failure of the connective tissue to hold it together. Right. The fascia of the muscles, the fascia of the vessels. I mean, these are connective tissue. So it plays such an important role in how our bodies are held together, and the way our bodies are held together helps us move. And when I think about all the difficulty with gait and mobility in our patient population, I think about the connective tissue. It's not holding things tight enough. And then because of that, the mast cells are releasing all these inflammatory mediators, of which, by the way, some of them are proteases that target some of the collagen fibers. And I think that there's so many different types these days. I think it's up to, I think there's 25, 26 collagen types. Some of them are fiber forming, some of them are non-fiber forming. That makes up the sort of the intracellular matrix. But regardless, there's so much to target within that connective tissue because there's so many components that once you have an inflammatory response that's perpetual and seemingly never ending, then you really have a problem on your hands.
And that's precisely the reason that we need to be discussing this and understanding it, because there are moments when we can intervene. There are actionable things we can do. So it's kind of, to take it away from connective tissue for a minute, we shouldn't start lowering somebody's cholesterol after they had their heart attack. We should lower it 20 years before, okay? We shouldn't start thinking about what can I do about your connective tissue now that you need a cranial cervical fusion. We have missed the boat. We lost the game.
I just got emotional when you said that, and I'll tell you why. Because when I went out into private practice 8 years ago now, I was actually going to do preventative care. That was what I was focused in on, because I recognized that very early on. I was just fixing people. I wasn't fixing people in the more, conventional settings. Yeah. But I was trying to fix people. But I was like, I got to get to the beginning of this for them.
Which, in fairness to you and to me and all of us, we're trained only to treat people after they have their heart attack, after they have their stroke, after they have a pulmonary embolus, after they have lung cancer.
That is right. I was going to prevent stuff. That's what I was going to, specifically at that time, of course, I was going to prevent neurological disease, because I just thought I was, I was the cat's meow. But in preventative care, because I had done all this training in integrative medicine, and I learned about all this stuff, and I thought, I'm going to prevent stuff. But what I quickly got into was, patients who couldn't get the kind of care that they really needed for various reasons. And that's another topic, of course, for a podcast. But so I just started seeing patients who have been sick for years but couldn't get any help. or wouldn't be believed, and couldn't get validation, and couldn't get someone to take them seriously. And so I just started taking them on because I thought I could prevent progression now. So that was like my next phase. I'm going to prevent progression of this disease. And then I got so deep into this chronic and complex illness world that I thought, we are missing the boat here, people. Like, we need other doctors to sort of join us and understand that these patients, we need to help them. We need to intervene as soon as possible. So now that's what my mission is, intervene as soon as possible. And the only way that I can see to do that is by what we're doing, is educating, the best that we can, because we're getting them late in the game, really. I'm playing catch up all the time.
And we don't have enough tools yet.
We don't have enough tools. We don't know enough.
Looked at this. So
right.
I think you would agree that the two challenges in patients like this is to address the sources of chronic inflammation, and how do we fix or repair or strengthen or reinvigorate the connective tissue.
Right.
So I think this piece, the chronic inflammation, for myself and Aaron, I'm pretty clear. I have a pretty clear idea of what we need to do, what to look for. I'm always finding something new that I didn't expect.
Yeah.
But nevertheless,
me too.
I understand, all right? And I'm always talking about or looking at new drugs that are way, way out of the box and not even...
Or even combinations of drugs that I'm finding now. Like, if I add this to that, like, wow.
Right, and that's another topic for a podcast. What role does crazy drugs like rapamycin and exosomes and stem cells play in this conversation? Right. So that's the inflammation piece. What I don't know... I mean, I know a little, but I don't know enough. How do we actually rebuild connective tissue? How do I take
that's the holy grail question, David.
I know. How do I take this person who I can see a year from now I'm going to have to send over to Paulo Bolognese? How do I prevent that from happening?
Right. Yeah. So that is a question I've been focused in on, really. When I was reading about the different, like I was saying, there's stem cells in that are in several different differentiated states. So some of them are completely undifferentiated and some of them are a little differentiated, though none are completely differentiated. Otherwise, they wouldn't be referred to as stem cells. But I thought, okay, well, we know stem cells are out there, autologous stem cells specifically. A lot of these patients are young enough where I think they are viable. I started to think about how we can capitalize on that new science and that new technology that many are doing to maybe move the needle for these patients, to sort of rebuild their connective tissue where nothing else is rebuilt. As you know, we're both big fans of GHK, which is a peptide that has been used in conventional medicine for wound healing and in burn centers because it helps to lay down the scaffolding for proper collagen deposition and layering. It also reduces scar tissue formation. And so it reduces the fibrotic kind of tissue formation, which further weakens connective tissue. So GHK has been a favorite of mine for EDS patients and hypermobility patients and other connective tissue patients, but and BPC as well. So I've been using some peptides, but I started to think about, but that only takes them so far, right?
And we don't actually have the data.
We don't have the data.
I agree with you, and I use them. But I would like even just one study that shows me before and after that it works.
Right. Well, I would like to give credit to the EDS Research Foundation, which was founded by Dr. Alyssa Zingman, and I serve on the board, on both the medical board and the executive board. They are going to fund a study on GHK.
Yes, that's
so I was going to talk to you about that because you have a lot of patients. Yeah. So I agree with you. We need data. We need research, and then actually at Mount Sinai we have an IRB protocol submission for autologous stem cells for EDS patients that's going to be reviewed in April. So it's, in the works kind of thing, but obviously not going fast enough for me to help patients in the kind of ways that I want to help them. And I just want to fix their connective tissue.
Well, yeah.
I say that all the time. Like, how do I fix this connective tissue, And you're right. A piece of the puzzle is reducing the inflammation, right? And we have a lot of that we have those tools. They're not always great, not always complete, but they do help a little bit for sure.
And that's along stem cells. That's the reason I'm so interested in exosomes.
Right, because they're easier
to give.
For sure.
And I think you're giving they deliver the major molecules, signaling molecules, and protein building molecules. It may actually be able to do that with connective tissue.
Yeah, and I would actually, and I know we keep saying this to our audience, and we're sorry, but we keep coming up with great ideas for podcast talks. I would love for us to like delve into what there is known about this regenerative medicine kind of thing,
Sure.
So that we understand it more and that we know more and we can better assess like, is it what patient it would be appropriate for and kind of thing. But so that's just another topic of conversation.
Yeah, well, I think the topics,
well, they converge
unraveling
for sure.
chronic complex illness and regenerative medicine are just like
right, because we say it's like
totally.
inflammaging, right?
Exactly.
Regenerative medicine is sort of was born out of this like longevity idea, like people want to live forever, they want to look young forever. But our patients, it's like aging, but at a faster pace.
Yeah,
so there's no reason why we don't apply regenerative ideas to our patients, right? So we need to start borrowing from these people. And by the way, there's a lot of money there, right? There's a lot of rich people who want to stay young forever, who want to live forever. So they put a lot of money into a lot of that science. And so I think we should optimize that. We should capitalize on that. And we should learn from them and see how we can apply it, appropriately, of course, and safely for our patients.
We can't wait for, I hate to say this, but we cannot wait for academic medicine to get there. No. Because our patients need it now. So, for me, and you and many of our colleagues in this sphere, we're taking drugs that are not normally used and using them because of the data that we do know. So a classic one to me is rapamycin.
Perfect one.
A drug that is used for kidney transplants. That's not what we're talking about. We're talking about a different dosage where this is now a very significant body of academic, well-accepted literature to show that in a low dose, it affects the immune system, enhances the immune system, reduces inflammation, reduces aging, prolongs life.
Yep.
From mice to people. Okay, the people piece is not proven yet, and probably never will be adequately proven because it's a trial that's very hard to run.
Right.
I think that may be, an amazing drug for our patients. I would like to prove it.
I completely agree. I think we should do a rapamycin study. I mean, as you know, we use it in neurology for diagnoses like tuberous sclerosis. It's an mTOR inhibitor.
Right.
It actually reduces the ability of damaged cells to replicate. I mean, that's the most simplest way I can describe it for now.
It's like a vacuum cleaner.
Exactly. So that's why it does what it does.
Right.
And that's why with tuberous sclerosis, these tubers form, right? And they form in the brain for the most part, which is what causes a lot of the morbidity for these patients. And so it reduces the formation of those cells because those are technically damaged cells. So so that's sort of the way to see it. And when I think about our patients, like, in their connective tissue, I agree. I think rapamycin should be better studied.
But it will take decades to get done the right way.
Decades.
Well, not the right way, to get done
the way
to
have a randomized control trial.
I mean, there are trials going on. UW actually has a registry, and
Yeah.
Matt Kaberlin is doing a lot of work, and he has this amazing dog
There
trial.
are pockets of doctors across the country doing it.
But I'm basically saying I want to treat patients.
Right. Well, yeah. I mean, they're sitting in front of us suffering. And I don't know about you, but I can't stand suffering. I hate when anyone suffers.
Right.
I have such a soft heart for these patients. And I just want to try something. And I figure that if I can find ways that I think theoretically holds a lot of water, and I do it in a safe manner, and that's usually just by doing very minuscule dosings at first and monitoring them closely. Like I feel... and while I haven't jumped that ship yet, I've been thinking about it a lot, about these different ideas that we can have. And it's just because we have no idea how to fix the connective tissue.
And just...
As opposed to like some of these other septad kinds of concerns, we have other options open to us that are well accepted and well understood.
Of drugs and
but it's the question that you brought up, like how do we fix this connective tissue that no one really knows, and that's why we have to start thinking a little bit harder, a little bit deeper, a little bit outside of our silos and these boxes, and put again, we're educated, we're intelligent, we're doctors. Like there's no reason why we can't come up with a safe plan for patients. So I feel strongly about that. And that's why my research has been now sort of heading in that direction. My reading has certainly been focused in on that, only because I just want to help more.
Yeah. Well, and you want to help more globally.
Globally,
right?
Yeah,
it's one thing to manage POTS. I'm not saying it's easy, but we sort of know what to do.
Right.
And it's one thing to manage mast cell activation syndrome. It's one thing to heal a leaky gut. But we have this global problem, which is the organism, the whole person, and this impact on their body and their connective tissue of chronic inflammation. And I don't think we're going to get there unless we're doing both roads at the same time.
I 100% agree with that. I really do. I know the answers for just about everything else, or at least an answer.
Or
I'm
at
not
least you
saying
know how to start.
I know how to start, know where to go.
Right.
I even know the right surgeons to call upon now. I've perfected what we do for patients, where I'm comfortable in most of the areas. I can talk about it at nauseum, and I know where to start, and I even know what to do next and next and next and next. And then sometimes I run out of like options, but then I think of like other creative ideas.
Right.
But it's this connective tissue issue that I think that we now need to sort of, you and I need to hone in on and figure out what we're going to do to fix that, because it's preventative, right? So once, of course, they have all those diagnoses like that, obviously we still need to fix it so it doesn't get worse, but I would love to be, early on in their progression and sort of really intervene and prevent all that from happening, all that progression.
If these useful but scanty data to date on rapamycin specifically is accurate, it's not just prevention, it's reversing.
It's reversing, absolutely.
There are N of 1 stories and then bigger, broader studies of people having their heart disease not just stopped, but actually fixed, reversed. They couldn't walk up a hill, now they can walk up a hill, that kind of thing. So
I'm thinking about using it for my brain tumors.
I think you should.
Oh, okay. My doctor said so.
I
read all the studies.
Yeah.
I really have. I've read a lot about it. So yeah, I agree.
It is used in cancer, not just tuberous.
I know.
But,
I know.
Yeah.
It was the tuberous sclerosis that I've treated many a time with rapamycin.
Yeah.
And then I just started thinking about how I apply it to myself. But I do think it could really be a useful part of a treatment plan for connective tissue disorder patients, for sure. Yeah. And then there's a lot of, I will say this.
But don't go out and buy rapamycin on your own, okay? It's not a completely harmless drug to our audience, I'm saying.
Oh, well, they can't buy it on their own, right? It has to be prescribed.
You can do anything on the internet.
Is that true?
I'm sure you could find.
Okay, well, maybe we should have that disclaimer. Like, anything we discuss here, please don't buy it off the internet.
Right.
You need to have a doctor's
there are side
prescription.
effects that needs to be monitored. It is ultimately quite safe, but not something you should just run out and buy.
Oh, that's a little scary to think that you can buy something like that off the internet. I didn't know that you can buy. Okay, I'm so naive. Really am. And actually, I should say that about peptides. I did recently learn you can buy peptides off the internet, but just so our audience knows, peptides are viable. So we have them compounded fresh, and they have a shelf life, and they expire, and then they're no longer useful. And so this I see on this in the supermarkets or in the drugstores, all these facial creams that say, we have peptides. Those peptides are dead. They're not going to do anything for you, right? So you need freshly compounded peptides to have any kind of medicinal therapeutic effect. And so that can really only happen through a prescription, unfortunately, but it really is the case right now, and probably the safer way to be anyway for patients, so that you don't waste your money because they're not covered by insurance. But because I do believe in peptides, and I see them now all over the internet.
Oh yeah.
So yeah. But I forgot. I was going to say another thing, and I forgot. I lost my train of thought there. But then there's other. When I think about connective tissue, again, I sit and I meditate on connective tissue. I think that I even think about some things that I've learned about the Ayurvedic wisdom of connective tissue, and I think that there are some interventions that the Ayurvedic world does to sort of help strengthen the connective tissue, and doesn't necessarily regenerate it, although perhaps over time it can. But there's different, and I forget the names because they're very long Ayurvedic names, but they do have a lot of systemic anti-inflammatory effects where it meant to tighten tissue, and it's based on your certain dosha, and I was always intrigued by those kinds of options. And then even just certain nutritional kind, there's then the Cusack protocol, but that's a whole lot of supplements. But there are some nutritional ways of approaching healthy connective tissue that I think can be useful. And I think I think nutrition can be its own podcast, and I can go into that another time because I think that's a long conversation. But, I don't want to act like it needs to be, aggressive and expensive and all this stuff, as our only ways of addressing connective tissue health, because there's other things that we know we can do. We know that autoimmune disorders definitely involve connective tissue degradation, and there are obviously treatments for that can protect the connective tissue in the meantime. So there's just a lot to be done, but when it's already damaged and I want to fix it is what we are focused in on.
So I'll press a one of your buttons.
Put a pin on it? Oh,
No, one of your buttons.
I gotta press
and
it.
that is mitochondrial health.
Oh, God.
And how it might relate
I
to
love
connective tissue.
mitochondria.
And, you know,
I love those little
that,
buggers.
like inflammation, is probably the root cause of so much of what we're talking about in our patients. I think we all say that. It's not easy to measure, or we can measure it, but we're not sure how to treat it, and we're not sure how to get the treatments into the mitochondria.
Right.
But it is a hugely important area.
Right. So so yes, I love mitochondria, as you know. Love to do mitochondrial medicine. I've done a lot of it over the years. Just to bring it back for a second to the stem cells, you know, there's lots of research, and I actually gave a talk about this at a stem cell conference. The stem cells actually transfer their baby, naive, brand new mitochondria to the damaged cells. Right. So those damaged cells sort of get a rebirth, if you will. So another just point about stem cells, which I'm really intrigued about and do believe like they're future of medicine. But mitochondria, yeah, I agree. I think that they try to keep up with with all the inflammation. I think that it's the inflammation that sort of burdens them, and over time they just sort of
they run out of steam.
They burn out. Right, they run out of steam. They burn out, and the electron transport chain does not work as efficiently. And it's like any other chain. Even if just one enzyme complex is not working well, it's like a link in a chain. Right, it's a weak link. Chain is not optimal, and it really does contribute to the inability of the body to regain control over the inflammatory response, or to come out of the cell danger response, right? So the cell danger is these three phases. It's a cycle. And usually our bodies will, you know, danger, cell danger response, we fix it, cell danger response is resolved. But it seems like in these chronic inflammation patients, they never really come out of the cell danger response, and which means that, you know, when they're in cell danger response, the cells are not talking to one another. So that biomass that's critical for organ function, including the connective tissue, is gone. And so there isn't proper functioning of it. Right. And so we need, and that's all about the mitochondria, frankly. It's the mitochondria.
And the treatment can be a range of things. It doesn't need to be drugs like rapamycin.
No, it doesn't have to be.
It can be zone 2 exercise,
right,
which increases mitochondrial biomass.
That's right.
It can be red light therapy,
all of these things support the mitochondria.
Which activates cytochrome C, which increases
HBOT
mitochondrial
actually is very effective.
There are a lot of other things out there. The problem, it's not a problem. The issue is
intermittent fasting is actually highly effective.
You know, mainstream medicine has not bought into these concepts,
right? And
so it always feels edgy to discuss it with patients, and accessing it may be difficult. But these are real things. There's a large body of proof for these things.
There is a ton of research about mitochondria, a ton of research about how to support the mitochondria. We know what's mitotoxic, as they call it. We know it's mitoprotective. Things that just help. And, you know, I always say, there's 5 enzyme complexes. Enzymes require substrates, which are usually nothing but vitamins and cofactors and vitamins. And so there's a lot of ways to go in that regard if you're just trying to support your mitochondria. Obviously, we're not talking about mitochondrial disease, which are usually either a mitochondrial genome variant or a nuclear variant that controls the mitochondria. We're not talking about a mutation necessarily. We're just talking about overwhelming, overwhelming burden on the mitochondria. So it's just, we're trying to support the mitochondria, and there's quite a few ways that we know how to do it. It's not always as effective as we hope. It doesn't always help everyone, but there are means of it. And I have this mitochondrial protocol that I used to use for kids with mitochondrial disease, actually, because there's no medication. Mitochondrial diseases often come with epilepsy, and so we were taught just basically control the seizures, and that's the best you can do for the most part. But there were a mitochondrial cocktail that we would give that would for sure increase their energy states, and that was by parent report. Like if they miss their supplements like for a couple of days, they notice a change in energy state, they notice a change in ability to communicate, in mood, things like that. So we do know that the cocktail itself has some effect for sure.
I have used them. I mean, I started out very skeptical, with a lot of these supplements.
Yeah, I remember when I started telling you.
You learn from the patients, and the patients tell me, yes, it helps.
It really does help.
I have 2 I get from one company that at least half the patients notice an improvement. When I did the oxaloacetate study, the Benegene, that's the brand name, oxaloacetate, I went into that totally skeptically and nervous because it was sponsored by the guy that invented it in his business, okay? 3/4 of the patients got better.
It's amazing.
Not better, but their fatigue decreased enough so that we could measure it. That's I
Right.
mean, that's very significant.
Very significant. And
that-
fatigue, addressing fatigue is important. I think we're off topic now, but no, I'm bringing it back to topic because what I'm about to say. So as you know, with connective tissue, I always say a cornerstone of therapy is a really good physical therapist and occupational therapist and manual therapies to sort of keep your body mobile in alignment, importantly, right? Because it'll easily go out of alignment, and not in the obvious like dislocation, subluxation kind of way. It's often very subtle, and even the craniocervical joint, for example. So I always say a cornerstone of a long-term treatment plan really is a good manual therapist that can sort of keep things intact. But in order to do that, where was I going with this? We need good mitochondrial.
Well, and
the fatigue.
You're right.
The fatigue,
I went off topic
right?
with fatigue, but my point was that the oxaloacetate actually gets
help the
into the
fatigue.
Krebs cycle in the mitochondria.
That's
helping the
right. That's
mitochondria.
exactly how it works, and that's why it's so effective for the fatigue. But the point is that if you're going to do this cornerstone of therapy, you need to be able to engage enough, right? And so, in fact, as you probably know, patients can't be sent to rehab facilities if they are not able to actively engage in the rehab to make it worthwhile. The insurance won't cover it. If they can't engage in 3 hours a day, I don't know whatever the number is these days, but they can't engage in 3 hours a day, that rehab facility won't take them only because they can't properly engage and they can't properly obtain the therapeutic benefit. Similarly, if a patient is too fatigued to engage in regular physical occupational therapy for their hypermobility and their connective tissue, or their physical activity, but again, importantly is to keeping alignment, then they're not going to get the benefit out of that regular kind of therapy. So that's why I focus in on the fatigue very often, because I want them to be able to engage in a good EDS literate physical therapist or a good EDS literate PMR doc who can keep them in alignment. And so therefore keep things, that signaling that I talked about earlier in the podcast will be more effective, more, optimal and provide better functioning of our entire bodies and specifically our organs. So fatigue is important. That was my roundabout way of talking about that.
Well, I mean,
so the fact that oxaloacetate was so effective.
Fatigue is both an outcome of the connective tissue insults,
right,
and a cause for further insult.
Exactly.
So
it's an important thing to address for sure. Exactly. And it could come as post-exertional fatigue, but it can also just be general fatigue.
Right. And I certainly don't want to leave the impression with our listeners, viewers, wherever you guys are, that it's easy. All right. Obviously, if it were easy, we wouldn't even be having this conversation. I mean, it's the whole fatigue that's part of the chronic fatigue syndrome picture is daunting. And I see it now in every long COVID patient. And it's hugely challenging.
It is very challenging, but so rewarding when you make a dent in it. So rewarding, not only for obviously us, but the patient. I mean, they can do so much more, and that is the key to sort of have them return to some level of quality of life, right?
Right.
Because it's not fun to live a life that, it has no quality or has less quality, I should say, or less function. Can't get tasks done, and so that's our goal, is to help them as much as we can. So yeah, connective tissue. So we're on it. We'll let you know in some future podcast episode when we have the answers. But thanks for this conversation. Thanks for at least listening in on our conversation. I enjoyed having this one.
Yeah, I did too.
But
I think we kind of
did
a little weaving.
Because there's so much to say. And I think we actually ended up with more questions than answers, frankly. But that's okay, right? Because that's what we're trying to do, is sort of, we want to start dialogue. We want dialogue amongst.
So where are your questions?
Send your questions.
Writing in. So give us suggestions of what you want to talk about.
I will say our Patreon page has been very active, with lots of questions and comments, and we love that for sure. So keep them coming and keep listening and watching, and thanks again.
Thank you. Bye.